I'm Dr. Sabrina Siegel with the Neuroscience Education Institute. Welcome to the NEI podcast. On this show, I sit down with renowned mental health care experts from a range of diverse backgrounds to discuss breakthroughs and best practices for treating patients with mental health conditions. We are here at the 2021 NEI Congress, and I have here with me Dr. Jeffrey Strawn. He just completed his presentation titled Recounting Neurobiological and Treatment Advances of Obsessive-Compulsive Disorder. Welcome, Dr. Strawn.
Thank you, Sabrina. It's great to be here.
And in today's episode, this is a very special episode where we are giving audience members a chance to get some of their unanswered questions addressed that Dr. Strawn didn't have enough time to answer while he was still on stage. So with that, our very first question for you is, which has better efficacy and tolerability between sertraline versus clomipramine for OCD?
Great question. And as we talked about in the presentation, both clomipramine as well as sertraline and the other SSRIs for that matter tend to have relatively good efficacy in treating patients with OCD. However, clomipramine really stands out in terms of having greater effect sizes, so larger improvements in patients with OCD. By contrast, though, as we talked about, there's oftentimes a price for greater efficacy, and that price comes in terms of tolerability. So with regard to clomipramine, we often tend to see many more side effects than we would typically see with an SSRI. Those generally can include many of the serotonergic side effects that we may see with SSRIs, like sexual dysfunction, weight gain, and so forth. But there are also some specific risks as well as tolerability concerns with clomipramine. So as we mentioned, I think it's important to obtain an EKG in anyone over 50 in whom we're starting clomipramine, or anyone under 18 in whom we're starting clomipramine. The other issue is in terms of really being careful about concomitant medications. Again, recognizing the fact that clomipramine behaves in terms of the electrophysiology like most 1A antiarrhythmics, in terms of depressing the activity of that fast sodium channel in the heart, which can result in some potential arrhythmogenic changes. The other issue with regard to clomipramine, as opposed to many of the SSRIs, with the exception maybe of paroxetine, is that we can encounter a whole host of anticholinergic side effects. So that can include the dry mouth, the constipation, etc.
Right. Okay, our next question is, what would you recommend doing regarding medical consent when the SRI dose needed is supratherapeutic?
I think there are really two parts to this question. One is in terms of the consent and the discussion with the patient. The other is in terms of the documentation. So first, with regard to the discussion with the patient, what I'll generally say, given that this is often a situation where we've had partial response, but not full response, is I'll talk about the evidence in terms of the studies that have been done for using higher doses. The other aspect of that is that if I do have pharmacogenetic testing, and let's say the patient is treated with escitalopram or citalopram or sertraline, again, medications that are metabolized via CYP2C19, and I know that patient is an ultra-rapid metabolizer, I can generally talk to them in terms of describing the evidence that we have for going to a higher dose, at least based on blood levels. Now, the other implicit part of that question is, how would I document this? So I would certainly mention that we've discussed the risks and benefits associated with increased doses beyond the FDA-labeled maximum doses. And my rationale for doing this, meaning partial response, or if I have pharmacogenetic testing, talking about blood levels and producing similar blood levels in ultra-rapid metabolizers compared to normal metabolizers. And then I would also document the absence of side effects, and that I will continue to monitor for side effects. So really documenting my thought process in the medical record there.
Excellent. Okay, our next question is, how much does CBT help OCD, cognitive behavioral therapy, help OCD, and can it ever be a treatment all on its own?
So cognitive behavioral therapy is incredibly effective for patients with OCD. And it certainly can be used as monotherapy. And many patients, particularly depending on the type of CBT, in other words, ones that really emphasize those exposures and help patients tolerate distress associated with those exposures and the associated cognitive changes in terms of violation of expectation and so forth. High quality CBT that incorporates those aspects can be highly effective.
Excellent. The next question is, have you ever seen what looks like OCD that might be more of a compensation for ADHD? What are your thoughts on that?
It's a really interesting question. And one of the things that came out more in our live discussion is the idea of thinking about obsessionality and compulsions and ritualized behavior in a big tent way. So as opposed to what we think of for OCD, which is a much narrower construct. And I think when we look at it from a treatment standpoint, at least with regard to our pharmacologic treatments, I think this is sometimes where we get into trouble because the evidence for psychopharmacologic treatments is really focused on obsessive-compulsive disorder as opposed to obsessions, obsessionality, cognitive inflexibility, many of the things that we would think of in terms of OC spectrum or OC big tent.
Mm-hmm. Mm-hmm. It's a really good point. The next question is, how do you classify and treat BFRBs, body-focused repetitive behaviors?
So treatment here for me really focuses on cognitive and exposure-based elements of CBT. I think that can really be probably the most effective treatment here relative to what we can offer in terms of our pharmacologic interventions.
The next question is, would you say we could use low doses of ondansetron to augment or treat OCD? What about in pediatrics?
So with regard to the evidence that we really have for treatments, as well as several SSRIs being approved for use in pediatric populations for OCD, specifically fluvoxamine and fluoxetine, as well as sertraline, I really tend to use those as first line and, in fact, second line, especially given that we know that treatment failure with one SSRI doesn't predict treatment failure with another SSRI. Mm-hmm. So here, I don't know that we really have the level of evidence that we would need, particularly in the pediatric population, to use ondansetron relative to some of the other medications that have substantially greater evidence.
Okay, the next question is, in pregnant women with OCD, would ondansetron be a good consideration? What about in this population?
So I like that the person asking the question was a bit vague, and that gives me some freedom here. I think that in terms of pregnancy, when we're thinking about medication, it's always that classic discussion of risks and benefits, but also there are a number of ethical principles that come into play in terms of patient autonomy and beneficence. And I think with regard to ondansetron in pregnancy, certainly we have great safety data, especially in terms of its antiemetic effects. Mm-hmm. But really, I don't know that we have comparable data for ondansetron relative to some of the other pharmacologic interventions. So I guess in terms of the actual patient being treated, I'd really wonder about the severity of the symptoms. If this is a patient with very severe incapacitating symptoms that in and of themselves are negatively affecting the pregnancy, I think I would move towards something that has more evidence. And specifically here, I might use an SSRI. That being said, in terms of SSRIs in pregnancy, there are some that I tend to avoid, and specifically that would be paroxetine.
Okay. That's very good to know. Okay, well, that takes me to our final question, which is, could you speak to the efficacy of N-acetylcysteine for OCD?
So N-acetylcysteine, I think, has probably been used for a potential treatment in almost every psychiatric disorder to date. It's been used adjunctively in affective disorders and schizophrenia and substance use disorders, tic disorders, in pediatric depressive disorders, pediatric OCD, adult OCD, and so forth. The studies that we have generally failed to demonstrate improvement over placebo. So while there are some open label studies that suggest some benefit, when we look at what I think are very high quality double-blind placebo-controlled trials, we fail to see benefit over placebo. That being said, it's an antioxidant. It has relatively few side effects. So I guess I'll leave that.
Maybe.
Potentially.
Okay, well, those are all the questions that I have for you. I just want to say thank you so much for giving people an opportunity to get some of these unanswered questions addressed. And thank you for being on our show.
My pleasure, Sabrina. Thanks again, as always.
Thank you so much for joining us for another episode of the NEI Podcast. Please let us know what you'd like to hear more about by leaving a review. Don't miss another episode. Subscribe today.